It's all yours.
All right. Good morning, everybody. Welcome to the 982nd meeting of the North Carolina Board of Pharmacy. I'm going to read the ethics statement. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and appearance of conflict. Does any board member have any known conflict of interest or appearance of conflict with respect to any matters coming before the board today? If so, please identify the conflict or appearance of conflict and refrain from any participation in the particular matter involved. Okay, looks like we're good, Jay.
Seeing none,
All right.
We can move into the consideration of the March 2021 meeting minutes.
All right. Did everyone get an opportunity to read those meeting minutes? Any questions or discussions? All right, seeing none, is there a motion to approve the March meeting minutes?
Motion to approve.
All right, we have a motion from Andy. Is anybody, Michelle is going to second that motion. So second. all in favor say aye. Keith?
Aye.
Bill?
Aye.
Wallace?
Aye.
Michelle?
Aye.
Andy?
Aye.
And I as well. So the March meetings are approved. March minute meetings are approved.
That's hard to say.
Yeah.
Madam President, we have two potential rulemakings to discuss today at the meeting. And the first is proposed rules to clarify limited service permit eligibility and pharmacist manager responsibilities for limited service permits. You all will recall, of course, that Bill and Wallace were are the limited service permit committee, and they presented to you at the February retreat a memorandum recommending certain clarifications, both as to permit eligibility and to pharmacist manager responsibility. And at the conclusion of and you do have a copy of that memorandum. And at the conclusion of the retreat, the board voted to accept the report of the committee and directed the committee and staff to prepare proposed rulemaking implementing that memo for your consideration at the April board meeting. And so that is what we have done. And Clint, do you want to give them the 50,000 foot overview? Of course, you have a detailed memorandum in front of you.
I won't repeat the detailed memorandum. This is one where, anytime in the drafting process that I pushed in one place, it squeezed out the other. And so there were a number of rules that had to be changed in order to adopt or propose the limited service permit rule. That rule is a new rule 1616 that starts on page 10 of the PDF. And it just incorporates the recommendations of the memo as to what permits should be limited service permits, and it incorporates really the only two substantive distinctions between a limited service permit and a full service permit, which are that you can be a pharmacist manager at more than one permit if all that are in excess of one are limited service permits. And there are different attendance and supervision requirements for pharmacist managers at limited service permits, and the memo proposed different amounts of supervision depending on the type of limited service permit. So, for example, for an automated dispensing device, it would require a quarterly visit to inspect and talk to the people who operate the device. On the other end, if you had a free clinic or a critical access hospital, there would be less attendance required than in a normal permit, but still a substantial amount. So in doing that, there were other rules that needed to be changed. Briefly, 1317 we got into because, which is a definition rule for all the other rules, got into to change the limited service permit definition. But once in there, it became apparent that a lot of the terms used in there have not been used in the rules in many, many years, if not forever. And that there are some that are slightly different from the terms that are actually used in the rules. So there was a general hacking and tightening process in there in order to get it hewed to the rest of the rules. 1703, there were changes to make it consistent with the, which is a PA/NP dispensing rule. There were changes to make it consistent with the limited service permit rule that is proposed. In addition, the memorandum that was presented to you proposed that the rule no longer purport to require the pharmacist to prepackage the drugs to be dispensed by the PA and NP, since that does not actually happen in reality. And then 1706 is the requirement for the pharmacist to review PA and NP dispensing, and that was changed to make it consistent and to import a slightly better list of what is to be reviewed from the definition section that was getting hacked out. And then 2502 is the PM rule. There were changes made in it to make it consistent with the limited service permit rule. In addition, as we were under the hood, so to speak, on that one, there were a couple of clarifications that could be offered to questions that are typically asked to board staff that we think are otherwise clear in the rules, but could be clearer to avoid some questions. And there was a provision about providing starter doses of medication, which the committee believed was both illegal and no longer a practice that really takes place. So that is proposed to be deleted. That was more than 1,000-foot overview, or less than 1,000-foot overview, but at least I was not in the weeds, I hope. But I can answer any other weedy questions that you have.
Unknown participant just joined, so we will alert the Project Blue Book about that. So board members, and obviously Wallace and Bill are here and we're on the committee, happy to answer any questions but that you might have. But again, coming back, the substance here does reflect the substance of the memorandum that you reviewed in February. But
it's been a couple months, Jay. Quick question. Does this have any bearing on a pharmacy that currently has a limited service permit and would need to get re-permitted to no longer be a limited service permit?
Yeah, there will be a handful of existing limited service permits. I can't remember the number. Well, I can tell you. I don't have to guess about that. There is a current census of 400 plus limited service permits. Out of those, there are 36 that would need to convert to a full service permit because they would not fit into. Now, they're also going in the other direction. There are 16 critical access hospitals in North Carolina that could convert from full service to limited service, and 12 health departments that could convert from full service to limited service. Now, of course, certainly they don't have to do they don't have to do that. That would be whether it would fit within their particular operations and the desires. But so it nets out of a change of about 8 among the population.
Okay, thank you.
You're welcome.
Jay, I forgot, the last thing in your package is a proposal to renumber Rule 1814 to 1419 because it is a healthcare pharmacy rule that is in the wrong place, which became apparent as I was referencing it in the rules. So any motion ideally would include that as well.
All right, any other further questions or discussion regarding this?
Ashley, let me bring up my only concern with the change from what the current ambiguous LSP rule allows and doesn't allow now. My only concern is that I myself had a full service permit in Hickory with a limited service permit under the same roof, and the only justification for that was to do with class of trade. The history was that LSP provided nursing home and hospice services to a number of patients, and because of the class of trade difference between a full service retail, we had access to certain contracts that we wouldn't have had access to under a full service permit. Now, that's going to go away, and I tried to make an argument for why we should keep that that ability for a pharmacist to have that. Another scenario would be a compounding practice within a retail pharmacy that had 2 permits, the compounding being limited service for the purposes of avoiding, I guess, for lack of a better term, certain requirements of a third-party contract. Also not a very good argument for not allowing or keeping the original rule. But I would like the other committee members to know that those scenarios will go away, and I just want to make sure that everybody knows that and is comfortable or doesn't know of a good reason why we shouldn't proceed with the change to the rules. And I just want to say for the record that after considering all the evidence or all the facts, I'm in favor of changing the rule to what we've changed it to. I'm not bringing that up to say I'm opposing it. I'm just bringing it up for full disclosure.
Well, didn't we talk about, ways around that? Jay, remind me, Bill, I mean,
well, I don't know that there is a way around the class of trade issue. I mean, if you're a retail pharmacy, I don't think, and my experience with all this may be very dated. Things may have changed. The whole class of trade argument may not continue to be an argument for providers of nursing home or hospice patients. I don't know. I guess this is where I'm looking to you guys for more information. Plus, we'll have public commenting where if there are other pharmacists who are going to be adversely affected, then that'll be when we hear. Wallace, did that answer your question?
well, I think so. I mean, we did talk about the public comment thing would give an opportunity for anybody that was aware of any issues. This would uniquely cause for them that would be the forum that they could come and express those concerns, and then would know exactly where it may potentially impact somebody that we're not really thinking about or really don't know for sure if it, like you say, Bill, that it's the same same situation. The same situation exists today that you're familiar with or not. So I think that's an opportunity for people to express or bring this any of these kind of things up. I mean, I guess that's what the public hearing's for anyway. So.
Well, the board staff did a pretty extensive dive into contacting existing LSP holders to see, what their reaction to this would be and whether it was going to cause any huge issues. And Jay reported on that at the retreat.
So I'm good with it. I think we put the staff put a lot of work in it, and we spent a lot of time on the phone, trying to talk through all the scenarios. And I think we've got a good product here.
All right. Is there any other discussion questions? And Wallace and Bill, you served on this committee, correct?
Yes.
Yes.
All right. Hearing none.
Well, let me just real quick, if I might, Ashley, I did just want to say another, and Wallace and Bill both mentioned it, the real substantial staff work that went into this was done mostly by Crystal and by Chase, who did do, and I think everybody's right. If we got a blind spot on that, on this in some way, we'll hear about that in the comment period, which is certainly appropriate. But I did want to be sure that Crystal and Chase got a public thank you for an exceptionally deep dive into the data on this, which I certainly made mine and Clint's job much easier. And I think you've heard Wallace and Bill say it really helped them too. So thank you to them for doing that.
All right. So is there a motion to publish these proposed rule amendments for notice and comment section? Okay, I think Andy just made the motion. He's on mute, but I'm pretty sure I saw him make the motion. Is there a second?
Thank you.
I'll second.
All right, so we have a motion from Andy, a second from Wallace. All in favor, say aye. Keith?
Aye.
Michelle? And she said aye, I think. Yep.
She did.
All right.
She did.
Andy?
Aye.
Wallace?
Aye.
And Bill?
Aye.
Aye as well.
Very good. Thank you all for that. And of course, Clint will get the notice proposed rulemaking to the Office of Administrative Hearings, and we'll get everything posted on the website and a public hearing date and all that good stuff out there. So members of the public or those we regulate who are attending today, just be aware that that's going up, and we'll publicize that further. If you have comments, there'll be a real clear direction on how to provide those, both in writing or at a subsequent public hearing. So thank you all for that. Madam President, I'm happy to move into the next rulemaking item. So as everybody knows, and we discussed at the February retreat, the board's telepharmacy committee has been looking at a variety of issues, and the one that has been designated the highest priority among those is proposed rules that would take essentially existing remote medication order entry authority, which exists for health system pharmacies, and expand their availability out to other pharmacy practice settings. The direction post-retreat was to come back with a report and recommendation at the April meeting. So that is what the telepharmacy has brought forward here. A telepharmacy committee has brought forward. This is, and again, I'll let Clint do the 50,000-foot overview, but in summary, what you have in front of you is a recommendation from the telepharmacy committee to consolidate remote medication order processing services and the centralized processing of prescription orders rules into a single rule consolidated at Rule 1816, which would deal with continues existing central fill authority, but would consolidate remote medication order entry processes. So, Clint, take it away.
Before I start, let me apologize to the ghost of Paul Lind, who was, of course, the center square on Hollywood Squares, not Charles Nelson Riley. But the rule that you have in front of you, as Jay says, consolidates the RMOE rule with the central fill rule so that a number of common requirements can be used to describe both services. The central fill rule is not changed in any substantive way. The RMOE rule is changed really in three ways. First, of course, is to expand it between healthcare facility pharmacies to any pharmacies where both of those pharmacies are permitted by the board. And it's subject to all the same sorts of restrictions about shared services and the like, shared systems. It would expand the existing RMOE rule, which allows RMOE services to be provided by a licensed pharmacist, to also include registered techs. As with the old rule, any personnel would have to be individually licensed or registered. Of course, techs can only provide services that techs can provide. They can't do counseling or whatever. So that is an expansion. And then I would say the third substantive change is with respect to mail order prescriptions or delivered prescriptions. It would permit the pharmacies to have a choice as to which pharmacy does the counseling. Of course, if a prescription is delivered in person, you can't just hand them a bag and say, "We'll call this 800 number." It has to be offered in the same fashion that it is currently offered. But anything other than those three are just stylistic changes.
So that's the staff high-level presentation. Obviously, we have the members of the committee who are also on the call. The committee is Andy, Keith, and Wallace. And so certainly if we've left anything out, they can fill that in, but happy to facilitate discussion and answer any questions that you might have.
I just want to say thank y'all for putting some teeth on this. So we're actually at a good point to move forward with this. So Keith, Andy, and Wallace, and all those others who's on there, thank you. This has been in the works for a while. So thank you guys for putting something in it that we can present.
And Ashley, I would like to say too that the thought that has been put into this by both the present committee members and by past members of the Telepharmacy Committee has been broad and deep and much appreciated.
Yeah, I was going to say, give Ashley some credit. She was on this committee before she took over as president. So she had a lot of input into this, as did Mr. Minton, a prior board member. So thank you to them as well.
Oh, Andy, you're on.
I was just going to say thank you to the external folks that participated at different times on that committee as well for bringing, your insights and experiences with that, maybe in other states or otherwise. I know COVID messed that up a little bit, but glad to get something on the books or at least moving in that direction.
So with all that said, is there any further discussion, or can we do a motion to publish these rules?
And, right. And to state for the record, Ashley, obviously that would be the option on the table is, again, just like with the last set of rules, I suspect there are going to be lots of folks who are interested in this particular rule. And so it will go up for comment, and I expect we're going to get some robust and insightful commentary. I think Bill's asking to be recognized.
Yeah, Ashley, I'd like to ask the committee who they feel will benefit most from this rule change.
I mean, I'm not currently on the committee, but honestly, I feel like that all pharmacies are going to benefit from this. Just from previous discussions that I had from being on the committee, I think that there's a lot of folks all around who are going to benefit from this. I don't know. Keith,
what's
Andy,
a real life application of it?
I mean, personally, who does somebody else want to?
Well, I was just going to say, application of it really is it's already been applied. With in multiple settings. We're just really just making some of it formalizing regulation of it, I guess, because with COVID, we've pretty much been allowing it to some degree. Correct me if I'm wrong, Mr. Campbell?
No, you're absolutely right that under existing emergency waivers, there had been, of course, hospital systems have been using remote medication order entry robustly, both between their own systems and outside providers of RMOE services. And then a lot of health systems use it internally too, where they have one hospital that will provide coverage for, it tends to be after hours, but not exclusively after hours in another hospital. But there, has been some substantial adoption of this in the context of long-term care. Certainly, community pharmacy has been the primary beneficiary of the waiver because community pharmacy practice settings sort of were allowed a tolerated form of workload balancing that was, well, let's just say it was not a perfect way to run things. But this does open it up. In terms of immediate opportunity, Bill, it will be community pharmacy primarily that will see this, not necessarily as a new opportunity given there have been waivers, but as a permanent opportunity going forward.
But I think overall the point is safety. This provides another level of safety so that, a busy pharmacist who is trying to give vaccines and, answer phones and answer questions in the drive-through and check prescriptions will have another layer of protection of somebody reviewing over prescriptions that were entered in and another pharmacist checking that before they get to that point.
And I think I'll say to echo too. I mean, I know hospital and retail things are different, but hospitals have been using this for a long time. I mean, we very robustly within our system used it and we have 2 critical access hospitals that we work together. I mean, basically people are looking at those two. There's one staff sort of that covers both of those places. It's a contractual arrangement between the 2 hospitals, but they both cover both places. So you got one pharmacist at Bertie, you got one, 2 to 3 pharmacists in Edenton. And so basically they're covering back and forth, and it works well. I mean, when the order queue is sitting there in front of you, you're seeing orders from both places, and whoever is available can go ahead and get it reviewed and approved and authorized, so the nurse can go ahead and get the medication and give the medication and those kind of things. So it works well in that. But then the rules that govern hospital pharmacy pretty much already allow those kind of things anyway, but this just formalizes a thing, cleans up a lot of questions in those areas, but also sort of expands that kind of option to try to help out in retail settings and ultimately impact patient care, because you're going to, like Ashley says, I think it builds in some more safety things, but also it's going to speed up the whole process for people. And I think that's just what we ought to be about, is trying to make sure that we improve safety, but also improve the product and that we're delivering to all of our patients. So.
Yeah, I mean, to Wallace and Ashley's point, I mean, having some previous experience in community pharmacy in a chain, despite best efforts sometimes with workflow and people have different duty assignments, even with a number of technicians in the pharmacy, you can have dynamics in place where a pharmacist ends up doing a lot of order entry and then checking their own work during verification. And so hopefully this provides an opportunity for more than one set of eyes to see a prescription and a validation process. And not throwing stones here. It's just the nature of community pharmacy and all the responsibilities going on. But I can remember vividly wondering at times, wow, I wish somebody else could take a look at this. I'm typing the order in and then I'm verifying my own work, which is obviously not ideal. With this scenario, once the companies figure out how to put it into practice, that could be a real help. So we'll see how it rolls out.
And services must be provided from permitted locations. Locations with
Correct.
pharmacy permits.
Correct.
So I couldn't contract with Keith to do verification during peak times and do it from home, right?
Well, yes. I mean, under the existing RMOE rules, pharmacists can operate from remote sites, which may be off-site from the pharmacy, but they have to be employees of a permitted pharmacy providing that. But yes, there are and have been under the hospital rule for quite some number of years now, the ability to do some remote site order entry tasks, and those are preserved in this rule.
Okay, so it doesn't have to be from a permitted site then.
Well, yes,
Well,
yes and no. I'm not trying to dodge it, but the pharmacy, the folks who are working from a remote site have to be employees of a permitted pharmacy and connected into that permitted pharmacy to be able to do all site
contractual.
So you could do a freelance
kind of thing.
I'm
I'm
sorry.
sorry. I was just going to say, or have a contractual relationship that, documents that connection. And then those pharmacists have obviously got to be registered in North Carolina and those kind of things.
Right. But if I were to contract with Keith to cover during peak times, I'd have to be an employee and have electronic access to his
record.
pharmacy system,
Correct.
just like as if I were standing in the pharmacy.
Right.
Correct.
Basically, it would treat you like a relief pharmacist if you were there on site.
Okay. Thank you for that clarification.
All right, any further discussion? All right, sorry, I thought I found the quietest place in the house. I'm remodeling a bathroom. Clearly, I'm not. I apologize. So is there a motion to publish this proposed rule amendment for notice and comment?
I'll make the motion.
Second.
I'll third.
Okay, so I think in the order it was Andy making the motion, and I think I heard Bill as a second, if that's okay. So all in favor say aye. Keith?
Aye.
Michelle? She said aye, saw it. Andy?
Aye,
Wallace?
but I do want to clarify that the guy with the hammer, I think, actually seconded the motion.
I think you're right. So sorry.
Is that Ken?
No, it's definitely not him.
Ashley is trying to gavel this meeting to order.
Yeah, I guess. All right, so we ended with Andy there. So Wallace?
Yes, aye.
Bill?
Aye.
And I as well. All right, so that goes up for notice and comment.
Very good. Thank you all, and we'll get all the appropriate things posted in all the appropriate places, and look forward to the comments on the draft rule. Telepharmacy committee members, on behalf of staff, thank you all. That this was not an easy thing to get through, not because it should have been, but it's just there are a lot of moving parts on this. So thank you all, and look forward to continuing on in the telepharmacy realm with some subsequent topics to take a look at. Madam President, I can give you very quickly committee progress reports. I've somehow managed to close one of my memos. Y'all, I'm telling you, there are some days that I think I've got the 3 monitors set up down, and there are some days like today when I'm not sure I can operate one monitor. But just a couple of updates on committees, other than the ones, of course, who have presented either today or last month at the meeting. The permit meeting Pharmacist Manager Education Committee, as reported last month, that is underway. That's Ashley and Keith, and they are being supported by Missy, Wendy, Josh, and Crystal. And remember that their task is to recommend amendments to Rule 1606 to potentially eliminate the in-person meeting requirement and replace it with some online educational materials and modules. And so they have met once, and there's work going on that, and with a deadline to bring some recommendations forward to the June 15th meeting. And then the other committee, the Intern Registration System Committee, that's Andy and Keith. And Andy and Keith, if you're wondering why, they're probably interested in an update too. Just a reminder that this is scheduled to have a report and recommendation presented at the board's July meeting. And board staff is continuing to gather information so that when the committee convenes, we've run down what we think are going to be some of the principal questions about how to do this. But an update on that, Missy and I met with staff at the South Carolina Board of Pharmacy to discuss their intern registration program, which of course it has a specific statutory basis, so we would be different than what we would have, but it was very helpful to get from Tracy Collier, who I think almost all of you know, the executive director down there, to give us some Missy and I some practical things to think through. We have also met with representatives from each of the 4 schools of pharmacy to discuss potential intern registration, and very specifically to discuss with them what sort of documentation and processes exist whereby students can acquire proof of current enrollment in a school of pharmacy and be able to submit that into a registration system. That was a very productive meeting. So we're continuing to gather up a little bit more information, but Keith and Andy, I suspect we're probably going to be ready sometime next month to sit down and talk about what we've gathered up and start moving towards some recommendations. But happy to answer any questions, of course, but to let you know that those committees continue to move along in the background.
Jay, I'd like to ask a question. I know that last month we formed an ad hoc committee on workplace safety issues, and I don't know if that committee had an opportunity to meet, but do we have any updates from that committee?
We did. We had some discussion, and that discussion is ongoing and has led to some suggestions to inspections and investigation staff. And what inspections and investigation staff are doing now are doing some retooling to our inspection and investigation forms and processes that are going to be designed to sharpen up our inquiries, either during an investigation or during an inspection, about what factors at a pharmacy in terms of staffing and workload and other things could potentially contribute to unsafe conditions. We are also having some outside discussions with some folks who are sharing with us some further information about what we need to think about. So, not trying to be cloak and dagger, of course, but I think and Andy and Keith, I don't want to get in the way of you two, but I think the discussion was that we had some focus and some orientation we could do that would help us in our investigations and inspections docket to, I think maybe a way to put it be shine a brighter light and bring some of those results back to the board members as part of our disciplinary process. So that is underway. Andy Keith, sorry if I think I mean to get in front of you there.
I don't want to talk out of school, but I guess the thing that I would say that Jay didn't say was, I think we found through our discussions that we had the tools necessary to deal with questions and issues that may arise related to this. We just need to use them, or maybe use them differently. And so what that's going to look like going forward, we'll talk more about that in the near future. But we didn't think that a rulemaking was a necessary part of dealing with the issue. Keith, did I articulate that well?
As always, you did. Really, like I said, the biggest takeaway, I'll reiterate what Andy said. We have we've already got the hoe and the shovel, so to speak, and we need to use those tools appropriately, and use what we got at our disposal before we go forward and try to reinvent the wheel.
And from a staff perspective, Keith and Andy were both exceptionally helpful in helping us think about how to sharpen, and to continue with all the homespun metaphors here, to how to sharpen the tools that we have to make them more effective.
Thank y'all for that update.
Yep, absolutely. I'll just pause to make sure there wasn't anything else on. All right. Well, Madam President, I'd be happy to move to the next item, if you like. This, again, as you all know, comes out of the board's February retreat, where we had a good discussion about technician ratios and the processes that the board uses to assess those and to approve them. And a direction from the members as a result of that discussion was to have staff draft a guidance document. And that's what this is. It's a guidance document. This is not a proposed rule or anything of that nature, but a guidance document that staff could both A, post to make generally available, and then B, make specifically available to pharmacist managers who are applying for a 5-to-1 or higher technician to pharmacist ratio increase. And because you guys had indicated that by experience and by wish, there are certain types of information that you find useful and important to your consideration of those ratios, and giving PM some guidance about that so they could get you the information you expect and need to make that decision. So what you have and what you've seen is a draft guidance document, and I would like to give credit to Missy and to Crystal, who took the lead in this project and working with their departments to come up with a guidance document. And there you have it. And what you'll see is this guidance document really does two things. Number one is it has a quick review of what the law of North Carolina is concerning technician ratios. It includes in that a reminder that under North Carolina law, it is the pharmacist manager who has accepted responsibility for the safe and lawful operation of a pharmacy. And that includes specifically a pharmacist manager's decision to ensure that there are sufficient personnel at a pharmacy to provide services safely. So it's a reminder there that it is the pharmacist manager who makes the decision whether to seek a technician to pharmacist ratio increase and at what level. It's a quick reminder that any request for a 5-to-1 ratio or higher by board policy comes before the board. And then the memo does, I think, what your chief objective was, which was to set forth the kinds of things that you find most helpful to your consideration of whether a particular proposed increase would be safe or would allow the provision of pharmacy services in a safe and effective way. And there you'll see them in those bullet points. I think that probably not a single one of these is surprising to you or would be surprising to anyone who was applying. I think mostly what this does is just spell out with some specificity exactly those things that you ask and review when making those determinations. So I'm happy to go through each of those individually or however you would like for me to do that, or answer any questions, or Missy and Crystal answer any questions. I would certainly be interested if y'all see that we left something out, something that you think is important to your consideration, what that would be. And I think, by the way, we have one, or Missy, I'm not sure if it's one or two, I think, pending technician to pharmacist ratio increases of 5-to-1 or higher. And so if this is approved today, we would provide this to those applicants for their consideration.
Yep, we have 3 pending currently.
Okay.
Personally, I think you guys did a great job outlining this, because I think in those bullet points, every single situation that's brought before us, that was very easy for us to navigate through. All those situations had every single one of those items that made it so much easier for us to see why we needed to do that or why it would be beneficial and not harmful for that pharmacy. So thank you guys for putting all that together, because I think that covers everything. Okay. Is there any other further discussion or questions? Bill, did you want to say something?
I was going to make a motion that we approve it.
All right. So it looks like Bill has made the motion to adopt the proposed guidance document. Is there a second? Keith is the second on that. So all in favor say aye. Wallace?
Aye.
Bill?
Aye.
Michelle?
Aye.
Andy?
Aye.
Keith? Keith said, I think he's muted, but he's aye and aye as well. So motion carries.
Aye.
Very good. Thank you all for this. And so Missy and I will get it posted and out to the current applicants right now or right after this meeting, and we'll adjust it as we need to going forward as experience. Missy, thank you to you and Crystal for your great work on this.
Yep. Thank you guys.
Let me move next into, well, I should pause. Actually, we're about 50 minutes into it. I always forget this might be the time to consider whether there are biological or other needs that need to be attended to.
This may be a good time because I think there's a lot of things going on in the legislation that may take us a little bit of time. So
I agree. I think this would be a good break point.
So everybody good with
Should
a
we-
10-minute break?
Yeah, you want to say let's why don't we reconvene maybe slightly more than 10 minutes at 11? Does that work for everybody?
That's perfect. That's
Okay.
perfect.
Great. Well, thus it shall be done. See you in 12 minutes.
Thank you.
Clint, as I was talking to you on the phone on the way in this morning, I immediately managed to spill coffee on my dress shirt.
Well, nobody knows. You didn't spill it on that 2 inches of collar we can see.
That is correct.
I'm sitting here putting in the Oxford commas just to keep Amanda from having stuff to do.
I am unabashedly a fan of the Oxford comma.
Blah, blah, blah. My 8th grade English teacher told me they were unnecessary.
She was wrong.
She was right. It's not substituting for the and or, so you don't need it.
Ashley, I feel for you doing remodeling stuff. I haven't had to do that in a long time.
Well, we just moved and
Yeah.
love the house we moved to, but I think I've told you this. I don't know if we're live or not. There's a urinal beside the commode.
Oh,
So that had to go. Yeah. That's
Did
not.
somebody have a doctor's office downstairs or something like that?
No. It was very, yeah, not my style. So we're redoing that.
You could put it in a bidet since it's already plumbed for that.
Yeah. So needless to say, they're tearing apart a lot.
that was my favorite part. Do you remember the old MTV show, MTV Cribs?
Yes.
And Rasheed Wallace was the guest on one of those episodes, and Rasheed had a urinal installed in his bathroom, and Rasheed was very proud of it.
It's literally right beside the commode, and so I haven't used it since we moved in, and I refuse to go in that bathroom. So now nobody can go in that bathroom.
Yeah. Remember the last time Amy and I did our reno of a bathroom was when she was very pregnant with the twins. And so it was dumb at a minimum to have chosen that particular time to do a renovation.
There's never a good time.
I agree. We've never built a house, largely because our experience doing limited renovation, I was like, we'll kill each other or the contractors or both.
Yeah, my brother-in-law is the contract. So my brother-in-law is the contractor and has been the contractor for us from the very beginning. And yeah, that can be a struggle. The struggle is real.
Yeah, good luck with all that.
The pricing is better, but the struggle
I'm sure. I'm sure.
All right, so let's see. It looks like maybe we're just missing Bill and Andy.
No, Bill's here. So Andy and
Andy
Wallace, as soon as they appear.
Okay, you can stop talking about me now.
All right, Ashley, looks like the band is all back on the stage.
All right, so I guess we'll hand it over to you, Jay, for legislative updates.
All right, and a lot more update this time around than last time, which is, of course, not a surprise. We're, still early in the legislative session, and some more bills are being filed. So let me start with the one that we know that is passed and that we discussed last month. As you all know, the General Assembly has passed, as part of the COVID-19 relief legislation, an authorization for pharmacists to administer long-acting injectable drugs pursuant to adult patients pursuant to a prescription order. And it authorizes the board to adopt temporary rules to implement that section, which is scheduled to become effective on October 1st 2021. Now, you guys also know that there is H96, a different bill, obviously, in the House that, if passed, would allow pharmacists to more broadly administer injectable medications with a proposed date. That there's no movement yet on that bill. And so I think that what we need to do is move on the bill that has become law, and we can pivot as we need to. And so in order, and Clint will correct me if I throw off, in order to have temporary rules or to have rules in place for October 1st, we really need to have proposed rules published by June of this year. Now, we can, under this statutory authority, we can unilaterally issue temporary rules to implement the statute. But because this authority comes within the broader umbrella of immunizing pharmacists, any permanent rulemaking, we think, would be required to be the product of that process, which you're familiar with, which is Medical, Pharmacy, and Nursing Board. So I think Clint is exactly right that even as we think about doing temporary rules, we need to do temporary rules that we think those boards would agree with. So we don't put out a temporary rule and then have to redo the whole thing. So all of that said is we think the recommendation from staff would be to put together a 2-member committee to work on rulemaking for this statute, and to bring that recommendation back to the full board no later than the June meeting. Clint, did I get the moving pieces correct?
That is correct. To do a temporary rule, it would have to be June. The permanent rule, we've already passed the date that we'd have to have it to be done by October.
But the temporary rule would put the statute in effect while we did the permanent rulemaking. So
I'm happy to serve on that committee if that's the will of the board, to form the committee and to begin work, because it looks like we need to move pretty quickly on that.
We do. And let me say, Ashley, while others are thinking about that, a couple of things that I have already done. I have reached out to staff at NABP and at NASPA, the National Alliance of State Pharmacy Associations. And I have asked both of those organizations to comb through other states' rules as they pertain either specifically to long-acting injectables or more broadly to injectable authority, and to compile for us some of those existing rules, and then certainly to provide any commentary that they would wish to provide on what they see are better or worse approaches to that. And I expect to get that material by the end of this week. So once I've got that, I could digest it, and that would, I think, give the committee a jumping off point instead of having the blank page syndrome.
Well, just for the record, there's really no reason why our pharmacists can't do this.
Totally agree.
I mean, if we can do immunizations, we can give a B12 shot.
I agree.
I'm stating the obvious, but just for the record.
And I don't think, Keith, that the rulemaking, at least from a Board of Pharmacy standpoint, should be all that complicated. There's a lot of, in terms of what records are required to be created and kept, and that sort of thing, that's already spelled out in the statute. So I think that probably the big pieces are going to have to be some adoption of a definition of long-acting injectable, so folks are clear about what the universe is. And there is reference in the statute to appropriate training, and I think that may wind up being us reaching out to the schools of pharmacy or others and saying, we need you guys to develop training that would cover any training gap that exists. And I'm not sure if there is any from existing immunization training. But I think those two issues are probably going to wind up being two of the main ones.
Well,
It's all prescription driven though, right?
That's correct, Bill. So that simplifies the task quite a bit.
So if a doctor sends me to Keith for injecting me with Depomedrol for poison ivy, then he can do it.
Yep, that's
Or
correct.
Depo-Provera.
I think one of the biggest issues that I see is we're not always trained on maybe like a deltoid injection. So to me, we would have to narrow that or receive additional training in order to do certain injections that way, because we haven't been trained to do that. So I think that'll be a discussion, obviously.
And that, Ashley, is obviously where your and others who are experienced immunizing pharmacists will be very helpful. Plainly, I do not have that skill or knowledge set to know where the gaps are.
Yeah, and I think I said deltoid. I didn't mean deltoid.
I think you meant to say thigh.
Politically
right?
correct here. The gluteus.
Gluteus.
Whatever. That's the one. That's the one that we don't have training on. The deltoid, we're good on that one.
Hopefully, Ashley, you haven't had too many patients coming into your COVID clinics and asking to receive their COVID shot in the gluteus. That would be awkward.
Well, as I tell my patients, keep your pants on, because you can take your shirt off, keep your pants on.
As Forrest Gump said, directly in the buttocks, it was $1 million shot. Jay, just for clarification, so timeline wise, our intention would be to have a temporary rule in place so that this can happen before October 1st. Is that what I'm gathering here?
Yeah, we want to be able to land it so that come October 1st, the rules are in place for folks to be able to exercise the authority. Now, how some of that timing works out in terms of any additional training that's required, obviously, that's going to depend on what the criteria are for those training classes and how fast they can get spooled up. But I think what we want to have in place come October 1st is at least the temporary rules that say, if you do X, Y, and Z, you can exercise this new authority that's been granted.
10-4, thank you.
Mm-hmm.
All right, do we have anybody else that would be interested in being a member of that committee so we could get to work on this?
I'm glad to do it. I don't, unless somebody else has a budding desire to serve on that particular committee, I'll be glad to join you, Ashley.
I think that's great, Andy. I think you bring the knowledge of the training class and how that can be implemented into this piece, which I think is a very important piece. So thank you.
You're welcome.
All right, Jay. So it looks like myself and Andy will be on that committee to get to work on that.
That's our guy. And I will get in touch with y'all early next week after I've had a chance to get this background material in and get it digested. So we can go from that. And we can also talk about strategies about how we draft any temporary rules such that if the broader injection authority were to get passed, maybe we can think about that drafting rules in such a way that they would be fairly easy to convert to a broader authority if we needed to do that. But I'll get to work on that and be in touch with you guys.
Jay, I have a quick question. NASPA, I'm not familiar with who those are. Do you mind?
Yeah, no, not at all. NASPA is the National Alliance of State Pharmacy Associations. So NASPA, among other things, often acts as a repository of what different states have done. Of course, NABP does this, but they often have a repository of rule schemes in different states governing expansion of scope of practice. So I reached out to Becky Sneed, who some of you know, Becky, who is the executive there, and just asked if she gathered up. And this ties into that occurred to me when Penny Shelton was doing a presentation about NCAP's legislative agenda and was using some NASPA resources. So I'm just trying to reach out to the places I think that might save us from doing some wheel reinvention on that.
Thank you, Jay.
Based on the little bit that I know about this, it sounds like the vast majority of states allow this in some form or fashion. So there should be some knowledge we can glean. So as you said, we're not recreating the wheel.
You're right, Andy. And the vast majority of states that allow it, that allow a broader injection administration of authority. And so that may wind up being our principal challenge, which is, not a terrible challenge to have by any means, is we may need to take some broader rules. And if we like sort of the cut of the jib on that, we may have to focus it down a little bit more for the existing authority being limited to long acting injectables. But like I say, I don't think we've been put in a position to write the Magna Carta here on that. So, well, very good.
I was in Raleigh and had a pretty long discussion with one of the senators, but it wasn't our senator, but it was one of the other senators that I've known for a while, and he showed me a draft of some information, or shared a draft of this, and and he was really lobbying for this, and I guess he might be a primary sponsor, but it was ready to be introduced. I haven't I followed up to see if it's gotten introduced, but there was, it's a pretty broad scope of injectable authority. So.
Yep. There's at least that one other bill, Wallace, is moving through H96 on that. So this information gathering that I'm doing of other states' rules will help us have some material in the back pocket if we need it, which would be great. Be a great need to have to do that. Let me move then on. So I've already talked about H96, S575. That's been newly introduced since we met in March of last year. This is a bill that, if passed, would grant to immunizing pharmacists and to clinical pharmacist practitioners a fairly broad authority to prescribe and dispense medications for the treatment of certain specific disease states, as well as there's discussion in there about the ability to administer CLIA waive tests, which you all know pharmacies with a CLIA waiver can already perform CLIA waive tests, but pharmacists can't prescribe off of the result of a CLIA waive test result unless it's a CPP whose practice fits that. But this bill would allow certain prescribing based off of the results of certain CLIA waived tests. It would set up or would require a joint subcommittee of the pharmacy and medical boards to get together and adopt rules concerning these new prescribing authorities. Would be required to develop a certification for pharmacists performing those acts, develop certain training, create a list of minor non-chronic health conditions that pharmacists could test for and then prescribe off of it. And then, somewhat strangely, says we would have to create a formulary of medications that could be used. So I think the big picture is this is a pretty exciting bill, in that it provides the kind of limited prescribing authority that, frankly, pharmacists in a whole lot of other states already have. I will say that I think that the bill has some substantial tweaking that needs to be done for purposes of clarity and the like, but I understand those discussions are being had. Now, this bill is sitting at last check, and I did not check this morning. I apologize. I was sitting in the Committee on Rules and Operations of the Senate, and I think you all know that's where bills go, and leadership in the Senate decides which of those bills will be parceled out to committees with the prospect of getting a hearing. So that could have changed since I last looked at this, but right now it's in Senate rules. And if it's still there, that would indicate there's probably still some substantial amount of negotiation occurring about whether and how this bill would be referred out to other committees for hearings. I don't know that there's a whole lot for us to do right now on this bill since we're sitting, but I certainly am interested in your suggestion. One possibility is that if the board is generally supportive of the notions of that are captured by this bill, could certainly communicate that to the primary sponsors and communicate that the board, as always, is ready, willing, and able to provide input and suggestion on the refinement of that bill. But I'll shut up and take your direction and thoughts on that.
My only comment would be whether it should be limited to just immunizing pharmacists and CPPs.
I think that's one of the issues, Bill, that I understand is being discussed right now over at the legislature, is whether it makes sense to put that under immunizing pharmacist or not.
But
it's a good question. Right.
I personally would love to see us encourage in any way possible that bill be moved forward.
Jay, so would you be able, with our support, to send a letter to those sponsors to say, yes, we are in favor of this and we'd like to, move forward with this?
Yeah, absolutely. That would be my suggestion, is that to send a letter to the primary sponsors saying that the board is supportive of this appropriate expansion of pharmacists' scope of practice to provide health care to their patients, and that guess we're on somebody's hold music is playing now. I'm just going to pause for a second, Ashley, and hope that we can mute whoever this is there. I think unknown participant was to blame for that. But yes, and say that we stand by to provide guidance and support and all of those sorts of things. If y'all are comfortable with me doing that, I am happy to do it, and could get that done today if you want.
Yeah, personally, I don't think this should be limited to just CPPs. I think that anybody that has that, who has got a PharmD could read a CLIA wave test and be able to determine if someone has the flu, if someone has strep throat. So I like to see it available to other pharmacists besides just CPP personally, because I think pharmacists are certainly capable of doing that, and rightfully so.
Just PharmDs?
Not necessarily. I think we're all trained to do that. I mean, I think we have to look at what they're proposing as far as scope of practice. I mean, it sounds like to me, Jay, that it's just limited to point of care testing right now.
Well, no. So there are two facets of this. There is one, that there is a list in this bill of certain health conditions that immunizing pharmacists and CPPs would be able to prescribe for independent of a CLIA test, right? And then there is a second tranche, I guess, which is undefined as specifically as the former, which would say that this joint committee of the Pharmacy and Medical Board have to come up which conditions by rule would whichever pharmacists were allowed under the statute, be able to perform the CLIA test and then prescribe on the basis of that test result. There are a lot of moving parts in this thing.
I just think we'd have to get deeper into it, obviously, to determine. Because I think, like Bill said, some of those things may need to be a CPP.
Yeah. I'm sorry. I'm going to pause again and say there is someone who just logged into this meeting who is unmuted and making a great deal of background noise. So could I pause for a second? Antoine, did we identify the? Okay. Just a reminder to guests, please, if you would, mute your microphone when you join the meeting. Thank you. But going back, so Ashley, yeah, I think there's a lot of potential detail here. And I guess what I'm most hoping is that by communicating with the primary sponsors, that you all, as the experts, the elected experts in this field, stand ready, willing, and able to offer that input to them.
I think that would be great.
That's what I'm hearing as my instruction, unless I see anything to the contrary. So I'll get that done today, Ashley. That's
great.
Thank you, Jake.
Thank you.
Most of the others of these, with one exception, there's nothing new. H29 is the verification of immunizations, immigration status. There's not been any movement on that since the last report. Same with access to prescription drug cost information. The HIE mandatory participation in enforcement. Again, these that I'm mentioning aren't specifically or even indirectly Board of Pharmacy issues, but just keeping you apprised on those. Yeah, sorry, Bill.
What is HIE? Is that health information something?
Health Information Exchange. It's a state.
Thank you.
State program. The PBM bill has been re-referred to the House, to the Senate Healthcare Committee, which is usually a sign that it's going to get a hearing, but I'm at least not aware, some of you may be, whether that there's been a hearing scheduled for that. S345, this is one I need a little bit of guidance from you all on. S345 overall is a bill that would provide a fairly comprehensive overhaul of the regulation of physician assistants. By and large, the thrust of that is to make physician assistants more independent in their practice. With that, what does that have to do with us? Well, one thing and one thing only. Under the existing physician assistant statute, it notes that physician assistants can compound and dispense drugs if they do so under the supervision of a licensed pharmacist, follow the rules governing the practice of pharmacy, and are registered with the board. In other words, as long as they comply with our PA dispensing rule requirement. This bill strips out that particular language and moves some of it to a different place and appears to create an unqualified and independent authority for physicians to, among other things, dispense and compound drugs and medical devices. Now, I really don't know whether that was the intent or whether this was just folks moving things around, but being careful about lobbing the kinds of grenades that often get lobbed at pharmacists when it comes to scope of practice type issues. I would note that there are hundreds of PAs that now dispense under dispensing PA rules and have done that for years without complication. I would personally have some concern, particularly with respect to an independent compounding authority, that if PAs were able to compound without any sort of oversight or apparent state law requirement that such compounding occur in the same way it must for pharmacists by following USP standards and all the rest, I do think that is a public health and safety issue. And again, I'm not sure that that's what was intended here, but I need some feedback from you guys about how to handle this. One suggestion would be that I could write a letter from the board to the primary sponsors and just say, hey, we've noticed this. We don't really have a dog in the fight about most of what this bill is about, but we noticed this movement of language just sort of as a reminder that PAs can dispense and do these things now, and just ask whether the intent here was to create a sort of standalone independent authority for PAs, or whether that they were just moving things around and some of the language may not have followed. So I need your guidance.
I think there's some room there to make sure, and I think I'm following everything here, to make sure that, you know, the same standards that are going to apply to hospitals, pharmacies, and whatever, as far as when it comes to compounding, which are you, especially if they got into some sterile compounding, that it should apply in all sites that a patient could receive those services. Because I don't want to take a broad brush but there's a lot of probably practice settings where things like even chemos are getting made and administered, and maybe not real. I mean, I think it's minimal, but the potential is there to and then we don't have any real control over any of that stuff. And so anyway, I think that if a letter is appropriate, that at least maybe questioning, is that the intent or something? I don't know. And see, but you don't want to get in a fight over something like that. So anyway, said enough.
So Wallace, to your point, is there a situation where a PA might be mixing chemo? Is that what you were?
Well, I mean, I think I've heard of things, and it's been some time, so it's probably cleaned up a lot, because the whole, everything is stripped. I've heard that there's, some sites, or heard of sites in the past where people were mixing chemo, and it may not even be PAs. It could have been a nurse, working under the supervision of the physician. And I'm not talking about like a chemo clinic where somebody's going and getting a bunch of stuff. I just think it's probably fixed itself over time. I haven't heard anything much about it recently, but I know of in the past there's been some situations, like that.
So Jay, I'm in favor of sending a letter to the sponsors, clarifying that, if everyone else is in favor of that. It seems like Andy and Keith are good with that.
Yeah, it sounds like the probably the three key points in a letter would be to seek clarification about what's intended. B, to remind the primary sponsors that we have a we have a process, or a longstanding process in place that works, and express this general concern that absent that, there's a risk that for compounding and dispensing functions, that you could have one group of folks not subjected to the same public health and safety standards that others are. That would sort of be B. And then C, as with the prescribing bills, say we are ready, willing, and able to provide education and guidance or feedback as appropriate. I think those will be the key points. If y'all are comfortable with that, I'm happy to do it.
Yeah.
All right. I will put that on my list. I'm going to be quite the correspondent this afternoon on that. All right, great. Thanks for that. Okay, I think the rest of these are relatively, well, maybe. S373, a new bill that's been introduced, that there's already a voluntary healthcare services statute that allows groups, for example, to come in and provide volunteer clinics for the underserved and the like. And there's some mechanisms by which those folks can come in. They have to notify DHHS, et cetera. This is just a change that would say that covered telehealth operations as well. I don't think we have a particular dog in that fight. Just making you aware of it. S515 is a very broad bill that would provide provide a statutory authority in excess of any ability under the federal or state constitutions that would allow a healthcare provider to opt out of providing, participating in, or paying for healthcare service that the provider objects to by way of conscience. It would prevent employers from taking any adverse action, and there's a long list in the bill of what those adverse actions would be against a provider who so objected, and would also tell an employer or a facility that any costs incurred as a result of healthcare providers exercising any right under this statute, that those costs, whatever they might be, or however high they might be, would not mitigate the obligation here. So, an incredibly broad, and of course would state that there's no civil, criminal, or administrative liability to a healthcare provider who exercised that right of conscience. So it's a very, very broad conscience right that's expressed in S515. That bill was referred to the Committee on Rules and Operations of the Senate. Again, I haven't checked. The effect on us just is a notice that how it would affect our authority in some way, but very, very broad bill. I think there was some substantial amount of press coverage of that when it was introduced. I'm not sure that there's really anything for us to do at this point except monitor that and see what, if anything, happens. And I just told you everything I know about that about that bill. Last one is the Universal Licensure Recognition Act. Y'all have seen this before. It was introduced in the last legislative session, and sort of the thrust of that bill is that there are apparently some types of occupational licensure which don't have any well-defined mechanism whereby somebody who holds that particular license in another state can reciprocate it into North Carolina. As you all know, we have a robust and easy to use reciprocity system for pharmacists. And at some level, I think the gist of this statute is to say to any licensing body that doesn't have a mechanism for reciprocity that you're going to have one now. I think, but it's not completely clear to me, that it wouldn't affect our existing reciprocity that we have with every state in the country, because it specifically says that it's not intended to prevent any licensing board from entering into a reciprocity agreement with another jurisdiction or to invalidate any existing reciprocity agreement. As you all know, we have that agreement with each and every state through our membership in NABP. But I think we need to keep a watch on this, because to the extent it can be interpreted as requiring us to create a parallel reciprocity process, and again, I don't think that's what's intended, that would be very expensive for us to reinvent that particular wheel. Clint, I don't know, was there anything you wanted to add to that? No, he says no. So I think all we can do is watch that. Like I say, I think the intent is not to disrupt existing reciprocity schemes, but we need to keep a close eye on it, so that we don't wind up having to have parallel processes. But that's as much as I know about that. I do know that some version of this has passed in a small handful of states, one of which was Arizona. And I do know that in Arizona, the Arizona Board of Pharmacy, their view was it did not impact their existing reciprocity national program. But I always worry about unintended effects with that sort of thing. So I'll keep an eye on that unless there's something further that we need to do. And I am not seeing anything. So that's the legislative report. And so let me just make sure, let me restate what I think my homework assignments are to make sure that I've got them right. The long-acting injectable rulemaking committee is Ashley and Andy. and that the next steps on that is I'm going to gather the materials I've requested from NASPA and NABP, compile those, and communicate with you two next week about how to get started tackling that. Senate 575, that's the prescription scope of practice expansion. Send a letter to the primary sponsor stating that the board is supportive of this appropriate expansion of pharmacist scope of practice, and that we stand by to provide any and all input that anybody would like on that. And more or less the same for Senate 345. That's the physician assistants bill, just to send a letter to inquire about what the intent there, reset the table on what the existing regulatory and easy to navigate regulatory framework is, and third, to offer our input as it's requested. I think I got all those right. Did I miss anything? See, I've gone to using note cards now for my, Amy says I need to have one pinned to my sweater most of the time. So that's, that's where we are on that. All right. Well, that is the legislative report. So if there are no further questions on that, Director of Licensing, Missy Betts, is standing by to give the licensing report.
Good morning. Can you all hear me and see me? Okay.
Loud and clear, Missy Betts.
All right. So, this is a big update for us. This marks the end of renewal for people and facilities. It's completely ended as of April 1st. The final numbers are in for pharmacy and DME. 3,413 pharmacies renewed and 771 DMEs renewed. And you can see in the chart that that's an increase from last year, which is, always what we expect. The final percentages are there: 99% of pharmacies, 95% of DMEs, and as you can see, those have increased as well. And then just kind of a note that any pharmacy or DME that did not renew were closed in the system. We sent them emails to that effect as well, so that there wasn't any surprise. And the numbers are there as well. It was about 30 pharmacies and 30 DMEs. 8 in-state pharmacies were closed and 13 in-state DMEs were closed. So those are the high points. If you have any questions, I'm here to help.
We were pleased, obviously, as you all know, especially Ashley and Michelle from the budget committee from last year. We just didn't know what was going to happen with this. And so it looks like, not to diminish in any respect the challenges that a lot of folks have had out there, but pharmacy has overall appears to have weathered it pretty well. So I know we're all grateful for that. So you all know too that in-state pharmacies and DME facilities, when we close them out for non-renewal, Ellen, Crystal, and Josh and their staffs do go out physically to each of those places to make sure that they have in fact closed, to give us complete comfort on that. So those visits will be occurring here in the short term. Missy, it was a smooth renewal season. You and your staff did a phenomenal job on that.
Well, I appreciate that. Thank you.
All right. If there's nothing for Missy, I will, our man with the plan, JP Brown's going to step in and give us the financial report.
Good morning, everyone. Just real quick, it's pretty straightforward. As Jay and Missy alluded to, we didn't really know what to expect in terms of renewals, and as Jay and Missy also pointed out, we surpassed what we conservatively had budgeted. That's reflected in the financials as well. In terms of operating revenues, we're already past 100K over our annual budget forecast, and then you can look in the details and see that like pharmacist renewals surpassed last year's renewal amount, as well as our annual budget. So anyway, yeah, just real quick, revenues have surpassed what we expected. Operating expenses continue to be lower than expected due to the pandemic restrictions mostly, as well as a lower than expected headcount. And that's, that lower than expected headcount sort of trickles through in terms of insurance and salary expenses and those sorts of things. So revenues are have a very large favorable variance, and expenses have a favorable lower balance. And that's sort of put us in a great financial position. And just a quick note, we are making concerted efforts to get done a lot of the projects that we had budgeted for. We have 3 months left. We're at the 3-quarter mark, and hopefully these next 3 months we'll be able to bear out some of those larger projects and get some expenses tallied up there and taken care of this year. Always happy to delve into the weeds if you guys want, but if not, I will turn it back over to Ashley.
Thank you, JP.
Thanks, everyone.
Thank you, JP. Any questions for him? Hearing none, it looks like Josh Kohler, you are the man on deck for the investigative report.
I think that might be a typo. I think Crystal is doing the stats this month.
All right, Crystal, you're in fact standing in the on deck circle. So go right ahead.
All right, as you guys can see, we have had a total of 91 cases so far this year, 41 substance abuse, 25 AOC charges, 3 diversions, 23 errors and omission, 13 inspection follow-ups, and 23 procedural legal cases so far. We have also had 7 total surrenders, 2 pharmacists, and 5 technicians so far this year. Any questions about investigations and inspections?
And so you all know Crystal and Ellen and Josh and their staffs are working on reintroduction into the field processes. So that's all underway.
Yep. We've slowly started to trickle back out and do inspections. We have some protocols that the staff is doing to go back out and conduct inspections and investigations.
Yep.
Thank you, Crystal.
Very good. Thank you, KB.
No problem.
Couple of reminders. Just remember that the NABP annual virtual meeting, although I shouldn't have said that, hopefully the last NABP virtual meeting is May 13th and 14th. I know you all know if you haven't already registered, but you would like to, Leslie's happy to take care of that for you. And NABP District 3, Cindy will be more than happy to take care of for any of you who want to attend. We can take care of both your registrations and your hotel reservations, which we are hopeful and confident will actually be a thing in October. So just a reminder that those are coming up. And remember, if the NABP annual meeting will be my valedictory address as a member of the executive committee. I'm certain there will not be a wet eye in the house when I am done being on the executive committee on that. But no, it's actually
it is
kind of that. I'll hang my hat on that, Keith.
I'm sorry,
but,
that was just too easy.
Easy, funny, and deserved. Thanks for that, Keith. But I think you all know that because I am now fully vaccinated and post the antibody period, I am planning to go to Chicago to be at NABP headquarters to do that. But the meeting itself will be virtual. So that's coming up. And that, Madam President, would conclude the discussion agenda items. There is, of course, the consent agenda, which you have in front of you. And we will need to go into a closed session for potential summary suspensions and a personnel matter. So
Okay, so do we have a motion regarding the consent orders and the pre-hearing conference?
I'll make a motion that we approve the consent agenda as presented.
Okay, so Wallace has made the motion. Is there a second?
I'll second.
All right, so we have a motion by Wallace, a second by Bill. All in favor, Michelle? Wallace?
Aye.
Bill?
Aye.
Keith?
Aye.
Andy says aye.
Aye.
Aye as well, so consent agenda is approved. So I think,
Very
Jay, maybe we need a motion to go into closed session.
We would just so just a couple of reminders from member of the public. Antoine, any comments or anything that that we need to address before we go into closed session?
No, there was no comment.
Okay, Antoine's volume was low, but I heard it. None. And just a reminder to those members of the public who are tuned into the meeting, when the board comes out of closed session, the only item that will occur will be a motion to adjourn and the adjournment of the meeting. So at such time as the board goes into closed session, if you would please log off from the call.
Okay, so do we have a motion to move into closed session?
So moved.
Andy and Keith with the second. All in favor say aye. Michelle?
Aye.
Wallace?
Aye.
Bill?
Aye.
Keith?
Aye.
Andy?
Ahoy.
Aye as well.